So I'm going for the metastatic setting, and there obviously there was a lot of new data and a lot of interesting data and a lot of interesting discussions if we should give in first line mCRPC the PARP inhibitor in combination with a novel endocrine agent. But again, this is only for the patients who had ADT alone or ADT plus docetaxel in the metastatic hormone-sensitive setting. And in reality, at least in a lot of countries, this is not anymore the patients that we see. But for the patients who didn't have a novel endocrine agent in the hormone-sensitive setting, so this combination has now been shown for 2 trials to have an rPFS benefit in a non-selected population. If you go and look into subgroups, the patients who really derive a lot of benefit are the patients with the BRCA mutations. And there is some benefit, but much smaller in the biomarker negative population. And so there was a lot of debate ongoing, should we give it to unselected patients, this combination or not? So interestingly, and also surprisingly to me, EMA has approved the combination for all comers in November last year. FDA has not yet approved this. Usually it's the other way around, so it's kind of interesting. Me personally, I am really convinced that for the BRCA mutated patients, we should do this, we should give the combination. I'm much less convinced for the biomarker negative population, because the PARP inhibitors have toxicities. So only because it's a tablet, it doesn't mean that it doesn't have toxicities. There is MDS, there is acute leukemias. It's not frequent, but if you give it long enough, it's very likely that will accumulate this side effect. And then there's anemia. About 30–40% of the patients had really need for blood transfusion. So in that sense, it's not a non-toxic drug, and we have to really find out who is this subgroup in the biomarker negative cohort that does derive benefit. And now we have a lot of data, and I hope the companies are going into that data and trying to find out who are these patients.